expiration and while lying down. It is aggravated during cold weather and while consuming cold products. Obstruction was not relieved on using Otriven nasal spray. History of left-sided nasal discharge, mucoid inconsistency, non-foul smelling, and non-blood stain. There was associated loss of smell. Patient has a muffled voice since 3 months, which was associated with snoring. Do I move to the next slide, sir?
Okay, go.
No history of recurrent episodes of running or itching nose, sneezing or watering of eyes. No history of bleeding from nose. No history of chronic irritation in throat. No history of double vision. No history of headache. No history of facial pain, trauma, or loosening of teeth. There's no history of earache, decreased hearing, or ear discharge. There's no history of significant weight loss. Treatment history. Patient has taken a course of nasal decongestant spray oxymetazoline consisting of 1 dose per day for a span of 3 days. Past history. No history of similar complaints in the past. Patient is not a known case of diabetes or hypertension. No history of asthma or tuberculosis. No history of surgery. No history of allergy to drugs. Sir, do I move to the next slide, sir? Personal history. Patient has a mixed diet with a normal appetite. The patient complains of disturbed sleep, regular bowel and bladder movements, no addictive habits. Family history, nothing significant. General physical examination. Due consent was taken from patient before examination.
Stop. Where? One minute. Nandini, 1 minute. Okay. So now go back to your first slide. This is a young lady with a history of nasal obstruction from an upper class patient with a history of 5 months nasal obstruction. Next slide. I'll go to your HOPI. She has got a complete nasal obstruction on left side and a partial obstruction on the right side.
Yes, sir.
Okay. So there is a positional variation. So and aggravated during cold.
Yes, sir.
And so not relieved using what it suggests?
Sir, it suggests of a nasal polyp because the patient has a unilateral obstruction, sir, which is not relieved on using decongestant nasal spray. And also because there is an increase in obstruction during expiration.
Okay, now now you have to be more. You should have a wider perspective. Don't concentrate on the diagnosis of your patient which she has. So now, when you say that the patient is not relieved of using nasal drops, what it indicates?
Sir, it indicates that So it indicates that if it's not relieved on using nasal drops, that it's not a hypertrophy turbinate or anything that could be, or a rhinitis or.
Okay, anybody wants to contribute or anybody wants to add? See, it indicates there is a mass lesion, so you need not be polyp only.
Yes, sir. Any mass lesion that does not.
Any mass lesion which will not shrink, which will not get decongested when you use any of these local decongestant nasal drops. So it indicates that it is a complete obstruction and there is no decongestion effect. Even if there is a partial obstruction, patient feels better with this local decongestion. So it only indicates that there is a complete obstruction and there is a mass in the nasal cavity, probably.
Yes, sir.
And we are not sure that what that mass is. And can you be able to tell that the reason for the right-sided nasal obstruction?
So the right-sided nasal obstruction could be because the mass, when as the mass grows in the posterior in the nasopharyngeal area, it may occlude the other choana as well.
Hmm. Okay. Any other thing? Any other possibilities? Any other possibilities? So the right-sided nasal mass need not be and need not be go through the choana. Any other possibilities? Any other possibilities which you can able to
Ethmoidal polyp, sir.
ethmoidal polyps.
It
Okay.
can be bilateral obstruction, sir.
So now the patient doesn't complain of a right-sided nasal obstruction, and you are saying that she has got a progressive nasal obstruction for the last 5 months. If the mass is pushing the septum, and it may cause an obstruction on the opposite side. So it could be one reason what you told is right, that there may be a polyp which is going into the choana and enlarging in the nasopharynx and causing obstruction, or it could be a nasopharyngeal mass going into the choana directly on the other side and causing an obstruction, or it could be a nasal mass which is pushing the septum to the opposite side.
Okay, sir.
Are you getting what I'm trying to say? Okay, these are the three explanations for the opposite side nasal obstruction, or as you are putting it, that the patient may be having the other side a hypertrophy turbinate or a polyp also, which is small. So that is why he is getting an intermittent nasal obstruction on the opposite side, and which is since the right side is completely obstructed, so patient is not bothered much about the complaints on the right side.
Yes, sir.
Okay. So then history of mucoid discharge is there, and there is associated loss of smell, and there is a change of voice for the last 3 months. Okay, next. Okay, so you have asked about this thing. So why you have asked about the history of bleeding from the nose?
Sir, history of bleeding from the nose to rule out juvenile nasopharyngeal angiofibroma, sir.
No, Nandini, you should be very careful when you are answering the questions. Why not? Why this? I am straight away saying that it is not a juvenile nasopharyngeal angiofibroma. Reasons.
Because the patient is a female who is.
So you should not
So in fungal sense,
tell
there could be a blood stain discharge.
when you know. Okay. Yeah.
Sir, I couldn't hear you.
Suppose this patient. Hello. Suppose if this patient has a history of bleeding from the left nostril, what are the possibilities you are going to think?
So
This particular lady.
So if there's blood stain discharge, we can think of
Hello.
fungal sinusitis, sir.
Okay.
So I'm not able to hear you clearly, sir.
If there is a frank bleed. Sorry. Now can you able to hear me?
Yes, sir.
Okay. So if there is associated frank bleeding from the nose, what are the possibilities you are going to consider?
So if there is frank bleeding from the nose, we can think of malignancy, sir.
Okay, very good. Listening it. Okay. Then hello.
Other than malignancy, So you're not fully audible, sir. I'm very sorry. I couldn't hear anything you said.
Some issue with the net. Hello? Yeah. Just a minute.
Yes, sir.
Okay. Hello. Shall I get connected to my phone? Nandini, can you hear now?
Yes, sir. Yes, sir.
Hello. One is malignancy. Yes, absolutely right. Any other possibilities?
So if there is crusting because of excessive crusting, when the crust that could cause bleeding, sir.
Okay. So now we are discussing about the possibilities of a nasal obstruction with epistaxis, unilateral nasal obstruction, progressive, and associated with bleeding. So frank bleeding, one what you told is malignancy. The other possibility, the most important thing you have to tell is a benign and a locally malignant tumor, that is inverted papilloma. Hello?
Yes, sir.
You have to keep inverted papilloma also in your mind. And other granulomatous conditions like your rhinosporidiosis is also a possibility, though it is a bilateral. Sometimes progressive nasal obstruction with epistaxis, you have to keep this common entities. Okay?
Yes, sir.
Good. Listening. So you have asked about history of double vision. Reason is?
So history of double vision to rule out trauma, sir.
Trauma. Okay. So in a progressive nasal obstruction, what you have told? You have told at a history level only we are. What is the differential diagnosis you have told is that malignancy. So though epistaxis is not there, hello?
Yes, sir.
But it is a rapidly progressing. So though you are saying that 5 months for a benign nasal mass to occupy the entire nasal cavity is little unusual. So this is on the borderline case. So from the, you are keeping malignancy also in your mind. So to look for any, whether this particular lesion has caused any problem to the, whether it has invaded the orbit also. So you are going to rule out that.
Yes, sir.
Because so it not that all the malignancies of the paranasal sinuses will produce bleeding from the nose. If
Yes, sir.
paranasal sinuses malignancy is like lymphoma of the maxilla or from the ethmoid, so cannot have an epistaxis as a presenting symptom. They will only present with a either a nasal obstruction or a swelling of a cheek. So in those cases, you have taken all these negative history like double vision, headache, facial pain, loosening of teeth, all these things you have taken associated malignancy in this particular lady. Very good. Very good. So, and you have taken about earache and ear discharge is why you have asked about earache, decreased hearing and ear discharge?
So because if there is any chronic infection in the nose or the nasopharynx, it can affect the ears.
Yes. So to rule out that whether there is any involvement of the ear, so you have asked that particular history also. Very good. And you have last sentence once again you have mentioned is significant weight loss.
So that
is
is to rule out malignancy, sir.
so you have considered all the aspects of this obstruction. So now you are saying that there is a patient has taken a course of nasal decongestion. So there is nothing like a course for a nasal decongestion. So usually when we say for an antibiotic, we say course. But for others like course, okay? Hello?
Yes, sir.
Okay, good. So next.
Past history, sir.
Okay, so past history is not having any contribution. So you have taken a general thing to rule out whether the patient has tuberculosis, asthma, and whether she has undergone any surgeries in the past. That's good. Next. Okay. So personal history, sleep is disturbed. Yes, because of this obstruction, patient not able to, yeah, well, that is okay. And there is, you have mentioned that there is a history of snoring also.
Yes,
Okay,
sir.
good. Listening it. Family is nothing significant. Okay, good. Good. Right.
May I read the general
Next.
examination, sir?
Next. Okay, yeah.
Due consent was taken from patient before examination. Examination was done in adequate lighting. Patient was conscious, cooperative, and well oriented to time, place, and person. Patient was moderately built and nourished. Vitals: pulse 84 beats per minute, regular in rhythm, normal in volume and character, no radial delay, no radiofemoral delay. BP 125 over 90 millimeters of mercury in the right arm in sitting position. Respiratory rate 116 beats per minute. Temperature 98.6 degrees Fahrenheit. Pallor, ictus, cyanosis, generalized lymphadenopathy, and edema are absent. May I move on, sir?
Good.
Nose examination. The external nose. The skin is normal. There are no scars or sinuses seen. Framework is pyramidal with no deformities. Palpation normal. Functional examination. Cold spatula test. There's decreased misting in the right and no misting in the left. Cotton wisp test. There's decreased movement in the right and there's no movement in the left. Smell. It is present in the right side and absent in the left side. Cortals test. It is negative in the right side and it is negative in the left side. Do I move on, sir?
Yeah, you keep on.
Okay. Tip raising test. Normal vestibule, normal columella, no crusting or DNS is observed. Anterior rhinoscopy. The nasal passages are normal on the left side and narrowed on the right. Normal on the right side and narrowed on the left side. Septum is normal on either side. The floor is normal on either side. The lateral wall, the mucosa is congested on the left side. Turbinates are normal on either side. Discharge is absent on either side. Mass, there is a pale, smooth, glistening, gray-white polypoidal mass that is filling the left nasal cavity. Lesion was coming out through the middle meatus into the nasal cavity. And on the right side, there is an absence of any kind of mass. Probe test is not done on the right side, and on the left side, there is a soft mass that can be probed all around except laterally, insensitive to touch and does not bleed.
Okay. Okay.
Paranasal sinuses, inspection, there's no redness or swelling seen. Palpation, all sinuses are non-tender on palpation. Posterior rhinoscopy, not done.
Okay. Go back to your nasal anterior rhinoscopy. Now, when you see, so now you have to be a little bit more conscious when we are presenting the findings like this. Now you are saying that there is a mass, pale, smooth, glistening gray, polypoidal mass filling the entire nasal cavity, isn't it? Hello?
Yes, sir. Filling the left nasal cavity.
Filling the entire left nasal cavity. And now you are saying that lesion is coming out through the middle meatus. Hello?
Yes, sir. I meant that there was a polypoidal mass in the middle meatus, and it filling the entire of the middle meatus, and it was seen coming out of the.
No, when the entire mass is completely occupying the nasal cavity, you cannot able to see the middle meatus area with your anterior endoscopic examination.
Yes, sir.
So you have. So I do understand as an undergraduate. Yes, you have a few of the limitations, and what you have done is good. But I'm trying to tell you the practical difficulties
Yes, sir.
you will encounter when examination is when you have got the entire nasal cavity is occupied with a mass. You will not be in a position to identify from where this is coming from.
Yes, sir.
So, and in probe test also. Hello.
Yes, sir.
The probe test also, you have to say that okay, it is soft in consistency, and now it is sensitive to touch.
Insensitive to touch, sir.
Insensitive to touch and doesn't bleed. So these are the only 3 parameters as an undergraduate you are supposed to understand. It is the consistency you are going to tell. You are going to tell about the sensitivity and whether it bleeds on touch.
Yes.
So you are not supposed to tell about that you can pass the probe all around except laterally.
Okay, sir.
Because it is very difficult for an undergraduate to do this examination.
Okay, sir.
So you just, if the examiner asks you that, can you pass the probe all around? It's the entire nasal cavity is filled with a mass, so it is very difficult. So it is impossible to pass a probe all around. So in there you are going to put your views with the examiner. So it is not that everything is possible to examine in the given case. So there will be some limitations and we have to accept those limitations. In this particular patient, the limitation is that you cannot pass the probe all around because it is filling the entire nasal cavity and occupying the nose. So you do not have a space.
Yes, sir.
Okay, so that is otherwise it is good. Okay, good.
Thank you, sir.
Right. Okay. Next. Okay, you have examined the paranasal sinuses and inspection is normal and palpations are all also. Posterior endoscopy is not there. Fine.
Oral cavity examination. Mouth opening is normal. Patient has good oral hygiene. Lips and commissures are normal. Tongue is normal in size. Surface is not coated. No fissures or ulcers are observed. Floor of
this is to all undergraduates. So you try to use less number of nose. If it is significant, then you mention it.
Okay, sir.
If it is not significant, tongue normal in kite surface is not coated. Fine. So you are expecting some ulcers?
No, sir.
Then why you are unnecessary commenting yourself? Okay.
Floor of the mouth is normal, sir.
Normal, yes.
Gingival mucosa is normal. Dentition is normal.
Good.
Retromolar trigone is normal, and the hard palate is normal.
Good, good. Right. What else? Okay, good. Okay, go. Oropharynx.
Oropharyngeal examination. Halitosis is absent. Uvula is normal. Soft palate is normal. The bilateral posterior pillars are normal. Posterior pharyngeal wall is normal, and indirect laryngoscopy is normal.
Okay, good. Anything else you would have commented? Now, this is where your a little bit of clinical knowledge comes into play when you are telling about the oropharynx. Though it's a little tricky for an undergraduate, but when you are saying a soft palate, anything else you would have told? Anything else you would like to tell?
Sir, you can in a case of nasal mass, you can say that no mass is seen from coming from the nasopharynx.
Yes. Then anything else?
A cleft palate, no cleft
No,
palate.
no, no. Pertaining to your mass and the soft palate. Nasal cavity mask, you are saying that the patient has got a hyponasality, and the other thing which you are going to supposed to comment is
Velopharyngeal.
huh? Is the movements of the palate.
Okay, sir.
Why?
Because of velopharyngeal insufficiency.
Not velopharyngeal deficiency. Your patient. Now you are talking about your patient.
So, because if the mass is coming into the oropharynx, then it could affect the movements of the soft palate.
Not oropharynx. Even if it is going into the nasopharynx, you are saying that no, hard palate ends and the soft palate begins. If this mass is completely occupying on the left choana, then that side of the movement of the palate will definitely gets restricted. So
Yes.
because of the mass lesion, that you are going to observe and comment in the examination. If you would have written more on the movement of the pellets are normal, yes, good. So and it can be lifted by the muscles of the palate.
Yes, sir.
What I am trying to say.
Yes, sir. Yes, sir.
Okay, good. Right.
Ear examination.
Good.
The pinna is normal on both sides. Preauricular and postauricular area are normal on both sides. Radial tenderness and mastoid tenderness are absent on both sides. External auditory canal is normal on both sides. Tympanic membrane on both the sides are normal, and a cone of light is clearly seen with the handle of malleus.
Okay, good.
Then the functional test. Rinne's test is positive on both sides. Weber's test is equally heard on both sides. Absolute bone conduction, there is no reduction seen on either ear. Facial nerve tests that are performed, it is positive. The patient is able to close the eyes tightly. Patient is able to blow the cheeks tightly on both the sides, able to raise both the eyebrows, able to stretch the neck on either side. The fistula test is negative on either side.
Okay, good.
Neck examination. On inspection, the skin appears normal. Trachea appears to be centrally placed. There are no swelling seen, no scars of visible dilatation or pulsations.
This is you people have the habit. You people have the habit of telling these no's unnecessarily.
Yes, sir. I'll take away all these from the presentation.
It is not only to you, because every time when we see these undergraduates, they keep telling if there is a pertaining to that, if you are having the patient has got any complaint, then you tell it. Otherwise, why you are, don't be too negative in your presentation.
Yes, sir.
Okay.
Palpation, trachea centrally placed. There are no palpable lymph nodes. Laryngeal crepitus is positive.
Okay.
Systemic examination. CVS, S1 and S2 sounds are heard. There are no murmurs. Respiratory system, normal vesicular breath sounds, no added sounds. Per abdomen, soft, non-tender, no organomegaly. CNS are no focal neurological deficits. Summary. A 37-year-old patient, lady presented with complaints of left-sided nasal obstruction since 5 months. The obstruction was insidious in onset and gradually progressive, increased on lying down and during expiration, aggravated during cold weather and while eating cold foods, and is not relieved with medication, associated with left-sided mucoid, non-foul smelling, non-blood-stained discharge. There was associated loss of smell, change in voice, and snoring. On examination, anterior rhinoscopy revealed a left-sided pale polypoidal mass in the middle meatus. On probing, the mass was soft and insensitive to touch and did not bleed.
Okay, good.
The diagnosis, then it is most probably a case of left-sided sinonasal polyp, likely an antrochoanal polyp.
Good. Right. So you are considering that left-sided sinonasal polyp, and with all the features, with your examination and clinical history, you are considering that it could be an antrochoanal polyp.
Yes, sir.
So how you are going to manage this particular patient?
So first, for management investigations, first there will be we would do a diagnostic nasal endoscopy, sir.
Okay.
And upon that, you can, with using a diagnostic nasal endoscopy, you can see the extent and the origin of the polyp, and if you can see if there are any if there is any discharge that has to, if there is a discharge, you can send it for culture sensitivity. Then after that, we do a CT scan, so a non-contrast CT scan of the nose and paranasal sinuses, which is the most important. From this, we'll know the origin and the extent, and you can confirm the diagnosis. Also, see if there are any anatomical deformities that need to be corrected. Then routine pre-op investigations will be done, sir. Complete blood count, hemoglobin count, clotting time, bleeding time, random blood sugar, ECG, chest X-ray, serum creatinine, and blood urea, HIV and HPSAG. These are the investigations we would do to confirm the diagnosis. And then for the treatment course, since it is an antrochoanal, since you confirm a case of antrochoanal polyp, there is no medical management. We can move on directly to a surgical management. Sir? Shweta, am I audible?
Yeah, Nandini, you are.
Is it sir? Like, is his video paused?
Yeah, I think so. He's not responding.
Okay. I'll just try calling him.
Okay.
Hello.
Yes, sir, you're audible now.
Sorry, sir. There was some network issue with me, so I'm just connected with my mobile. Sorry for that. Okay, no, right. So where were you? Okay, investigations. Yeah.
Yes, sir. And from the investigations, we can confirm diagnosis of antrochoanal polyp, sir.
Okay.
For which case we will do a surgical management will be followed instead of a medical management.
Okay.
So, a surgery, fast surgery can be prescribed for the patient, sir.
Okay, we would like to do a functional endoscopic sinus surgery. So, is there any medical line of management for this?
So for antrochoanal polyp, there is no medical line of management. So if there is a chronic sinusitis associated with it, then the patient can be given antibiotics, decongestants, nasal.
No. This patient will ask that, doctor, can I get medicine which I don't mind buying, even if they are too expensive? Also, I don't want a surgery.
So steroid nasal spray, sir.
Okay. So you want to give a steroid nasal spray for this so that it will reduce in size?
Since the polyp is an inflammatory condition, sir, by giving a steroid nasal spray, it may help.
It will help, but it will completely eliminate the patient's problem?
No, sir.
Okay. Then what is your advice to the patient?
We can tell the patients that no course of medical management medicines can help with this, and we can explain the etiology and the problem to her and tell her that the definitive treatment is a surgical management, and also we can tell her that in this condition recurrence rate is very low, so she doesn't have to worry about it once the surgery is done.
Okay. It's at what stage of the polyp you will have medical management will work?
So if the polyp is still sessile, it has not been pedunculated, you can try medical management, sir.
Very good. So what are the stages of polyp formation? It is okay.
First there'll be a prolapsed
Okay, the stage of edema, that is edematous stage, polypoidal stage, and polyp stage.
Yes, sir.
Think it. So the polyp means it usually once it attains a stalk,
Yes, so
then
once
you
it is
call
peduncle,
yeah. So then it is not amenable for your medical
medical.
line of management. So if it is still in the polypoid stage and in the mucosal edematous stage, you can try a course of oral steroids, or if need arises, you can use a nasal sprays and nasal wash that will help to bring the symptoms of the patient. But the surgery is the only answer if done in a proper way. Okay.
Yes, sir.
So what are the steps of, do you know what are the steps of this functional endoscopic surgery for a polyp?
For a polyp, yes, sir. First we must do an uncinectomy, sir.
Okay, good.
The first stage of it is uncinectomy. Then you identify the maxillary sinus ostium,
Okay.
and you do a we'll do a middle meatal antrostomy, which is widening the middle of the ostium of the middle meatus of the maxillary sinus. Then, sir,
Okay.
we will take out the pathology. We'll take out all the disease from the antrum by doing a wash.
Good.
And if it is contained to just a maxillary sinus, sir, I think this is enough. But if you have to even investigate and further go into the anterior ethmoids, then we have to then do a anterior ethmoidectomy, sir.
Okay.
A bullectomy and then an anterior ethmoidectomy.
Okay. For the ethmoidal, for your
Antrochoanal.
antrochoanal polyp, you are going to do an uncinectomy and a wide middle meatal enterostomy.
Yes, sir.
So what is the instrument which you use?
The instrument that we use is the backbiting forceps.
Okay. Then now, because she is a software engineer, no, you are saying that. She
Yes.
says that, doctor, I can afford anything, so cost is not an issue for me, but I want the best uh, possible outcome for the surgery which you are going to do.
Yes, sir.
So what is the best instrument for the polyp surgery? What is the most preferred method of doing polypectomy?
And
More so, huh?
endoscopic, sir.
Endoscopic only. Now the conventional with a headlight, the polyps are not going to be uh, helpful. So you are going what is known as a microdebrider.
Yes, sir.
Have you heard about that?
Yes, sir. It is a cold method of.
Okay, microdebrider is a tool which is used to debride all the polyps from the nasal cavity.
Yes.
So conventional method, what you are saying is that with a
Conventional,
back.
we use a Blakeslee forceps to
Yes, very good. So
neck
you
of
can
the
use.
polyp, pull it out, and then the backbiting forceps for the middle meatal antrostomy, sir.
Okay, okay, very good, very good, very good. So, so what are the complications you can expect?
So in FES, there are two types of complications that we can expect: major and minor complications. Minor complication is the nasal cavity hemorrhage, crust or synechial formation between the middle turbinate and the lateral wall, or the middle turbinate and the medial wall, sir. The major complications, intracranial complications like injury to the cribriform plate that can lead to CSF leaking. There could be meningitis, or there could be injury to the parenchyma of the brain. There
Okay.
could, which could also, then meningitis could lead to a brain abscess. Orbital complications like hemorrhage due to uncontrolled anterior ethmoidal artery injury, or so there could be a medial rectus injury, sir, which can cause diplopia.
Okay.
And there could be injury to the optic. The most dreaded complication of PES is injury to optic nerve or internal carotid artery, sir.
Okay. Good. Unmute. Okay, that was a nice presentation, Nandini.
Thank you, sir.
So I think few of the
So you're not completely clear, sir. Like you're not completely audible. It is getting cut. Can you please repeat it, sir?
okay, just a minute. There is some network issue with me.
So the thing is, you can't be in the same place. You can't have logged in from two different devices, sir. There'll be an
No,
error.
Hello, can you hear me?
Yeah, so just mute one device, sir.
Okay.
Log out of one device, sir.
I've done that. Okay. Okay.
Can you please try now, sir? Please unmute yourself, sir, on this device. So please unmute yourself from in this device, sir.
Okay. Now, can you able to hear me?
Yes, sir.
Okay, that's good. So there was a really an excellent presentation, and the flow was very good, and we
Thank you, sir.
were able to discuss a lot many things on nasal masses. So let us see a few of the things, because can I have can I enable my screen to be displayed?
Yeah, yes, sir. 1 second, sir. Shweta, could you please make sir the co-host?
Yeah, sir. I have.
Yeah, so
You
you
can share.
the screen, sir.
Okay. Where it is? Okay. Can you see my screen?
Yes, sir.
Okay. So as we have heard Nandini discussing about the polyps, so let us see few of the things uh, pertaining to both the antrochoanal polyp and ethmoidal polyp. I know that by this time all of you know the differences between antrochoanal polyp and ethmoidal polyps. A lot of the things have been discussed on that. So we will be touching few of the clinical aspects that which we come across in dealing with this polyps. Now I have put a scan films. This is what she was telling about the CT scan of the paranasal sinuses. So she told non-contrast. Now you should not be unnecessarily commenting the things. So it is the radiologist who will decide in the gantry where he has to use a contrast or he is not supposed to use a contrast. Your job is, what you want is, you want to know what this mass is. Never be biased with the diagnosis. So there can be a lot of surprises too. Okay. Hello.
Yes, sir. Yes, sir.
Okay, so now I have put a 2 scan in the presentation. So can you able to make out the differences in the 2 scan and what is the diagnosis for
Yes, sir. The
first one and what is the diagnosis for the second one?
So in the first one, a mass. Sir, in the first picture, a mass seems to. So you changed it. In a first picture, the mass seems to be arising from the maxillary antrum. But
Very
in
good.
the second picture, the mass seems to be coming from the cranial cavity, sir.
Yes, very good. Very good. That is very nice. So what is the probable diagnosis for this?
So that could be a meningoencephalocele or a meningocele, sir.
Very good. So this could be a meningocele, and so you should not unnecessarily, that is what you should be careful, because both of them clinically look same. The only thing is that this polyp is insensitive, this is sensitive, and you can able to see that. Why not this could be a sinusitis? Why not this particular thing which we are seeing is a sinusitis? Is you can see a widening of the middle meatus here. Look at this. This is the middle meatus here, and you can see that this is the middle turbinate. For those people who are not very familiar with the CT scan, I'll just go through this. This is the orbit. These are the maxillary sinuses. So these are the ethmoidal sinuses. This is the nasal cavity. This is right nasal cavity. This is the left nasal cavity, and this is the septum. So these are the inferior turbinate. You can able to see that inferior turbinate is hypertrophied. And in the same case, what Nandini has just described now, it is exactly could be opposite side. Like she has told that this obstruction is on the left side. Now in this particular patient, the obstruction is on the right side. So now you can see that this widening of the middle meatus usually indicates that the mass is coming out of the middle meatus. In sinusitis, you don't see this widening of the nasal cavity. Otherwise, the picture will be the same. The second thing is, yes, the one of the other differential diagnosis which you will be, everybody will be telling is for antrochoanal polyp is the inferior turbinate hypertrophy. Look at this. This here, the entire maxillary sinus is normal. The ethmoidal sinuses are normal, and you can see that the right nasal cavity is hazy, and you can able to see that this entire thing is from the inferior turbinate. It is nothing but inferior turbinate hypertrophy what you are seeing.
Yes.
So this is one of the differential diagnosis for your antrochoanal polyp, unilateral hypertrophied inferior turbinate. The differences is, once again, it is sensitive to touch, and this is firm, this thing, soft to firm, whereas your polyp is soft in consistency. Okay. So next we'll move on to this one. So since we are discussing about the polyp, so let us see this particular thing also. Now here you can able to see that all the paranasal sinuses are completely filled with a soft tissue density. So this is a case of bilateral ethmoidal polyposis. Okay. So you can see that the maxillary sinus, the nasal cavity, the ethmoidal sinus, the frontal, this is the frontal recess. So all those things are filled with the soft tissue. Now this is the axial view, and that is the coronal view. So this is the most important investigation. So the two important investigations for a polyp is, one is diagnostic nasal endoscopy. The second thing is CT of the paranasal sinuses. And for the surgical preparation, you ask for a routine blood investigations. So then this is what is the conventional polypectomy, which now just now she has described. So you can see that this is working on the opposite side of the nasal cavity, and you can see the mass is coming from the choana, what exactly she has explained in her case. Now you see that the polyp is coming from the middle meatus, and the Blackesy forceps which she mentioned. So we are holding it and just pulling the polyp. We are holding at the neck and delivering the polyp from the maxillary sinus. You can see that this is coming from the maxillary sinus. Then now you can able to see that the space, this is the uncinate process. So what she has mentioned, that uncinate process. So you can either use a backbiting forceps, or you can use a true cutting forceps. So this is a part of the uncinate, and this is the angled Blackacy forceps. And now this is the backbiting. So the inferior part of the, you can see that opens backwards, and now you are grasping the part of the uncinate and taking out. It will have a true cutting effect. Then in the end, you will be seeing that middle meatus is completely widened. You can able to see that widened middle meatus, so that it will be helpful for the inspection of the sinuses for the future examination. Now you should not come too anteriorly. What can be injured? If you come too much anteriorly in case of your backbiting, you may injure the nasolacrimal duct and patient may present with epiphora. And what you are seeing is the maxillary ostium, and now we are widening the maxillary sinus, that by doing a middle meatal, widened middle meatal antrostomy. So you can go up to the posterior wall of the maxillary sinus also. This is with the help of a conventional instrument. Sorry.
Yes.
So now, so this is what I was talking to you. This is the microdebrider, which is used for in majority of the functional endoscopic sinus surgery. So these are the different blades which we have. This is the console. This is the handpiece. So how this works, we will also see that. So, and this is one of the differential diagnosis for your ethmoidal polyp. So now bilateral inferior turbinate hypertrophy. Now you can see that this girl has come with a nasal obstruction, and with a tip rising test, you can able to see that both sides of the nasal cavity is completely filled with the nasal mass. And on the right side, you can see that this appears to be pink, and on the left side, it appears to be a pale. But usually we have been taught and we have been seeing that the polyps are usually pale. So that is why we thought that it may not be polyp. So it could be just a turbinate hypertrophy. And now you can see that how a turbinate hypertrophy, to what extent the turbinate hypertrophy can be there. Look at this. So this, as if it appears that it is a polyp, but this is basically a turbinate. You can able to see that this, when I move that, your entire lateral wall moves, and you can see that this is attached here, and this is too much boggy turbinate. Very rare to see such big turbinate. This is in a 10-year-old girl. You can see that I cannot able to reach my nasopharynx without pushing the turbinate backwards. So what we do usually for this are just a partial turbinectomy for this. So this is about the turbinate. Now, sorry. So this is a bilateral ethmoidal polyposis. A case of a bilateral ethmoidal polyposis. So you can able to see that multiple. Now you have been explained, no? Classical grape-like multiple tail. Now you can able to see this surrounding the turbinate is pink and this is pale. So in the first class also I have told that it is the visual impression that is most important for an ENT surgeon, because we see everything. And this is the merosil which we are using. So you should be able to know these different packing materials available. So the one of the packing material is merosil, and now you can able to see that how the debrider works. So you can able to see that this cuts, sucks, and takes the polyp in it. So it has got a lumen inside it. So it cuts and sucks the entire thing which is coming in its way. So, but unfortunately, the debrider doesn't know which is polyp and which is turbinate. You can able to see that this is the turbinate and this is the polyp. The surgeon behind the instrument knows what is normal and what is abnormal. So because inadvertently, if you touch the turbinate, it will start bleeding profusely. And one of the important things for an endoscopic sinus surgery is that we want anesthetist to give a hypotensive anesthesia so that during the entire course of your surgery, the bleeding will be very much minimal so that you can able to see all the structures. Because especially when we are doing an ethmoidal polyps, so we are near to the critical structures by millimeters. So maybe your anterior ethmoidal artery, maybe your orbit, maybe your intracranial, your preform plate, all of them are quite close to the polyp. So you have to be more careful while removing these polyps from the critical areas. So now, once the surgery is done, so so this is a small video which shows that every surgery has got a complication and it can occur with any of the surgeries, any of the surgeon. And there are, as she has rightly mentioned, there are major complications and minor complications. Minor complications are acceptable, but you should never cause a major complication because it is disastrous. So let us see one of the small minor complication which has occurred in our own hands is this one. Can you able to tell what it is?
Sinus formation.
This is a sinus formation in between your middle turbinate and the in between your inferior turbinate and the septum, because the nasal cavity is too vascular and any raw area created between these two sides will cause an adhesion. So the patient now post-operatively will be normal for some days, and once again he comes back with nasal obstruction. And when we do a diagnostic nasal endoscopy, we do encounter this small problems and we have to explain them, and on OPD basis or on a daycare basis, we can admit them and release them. And either we can put a stent or we can put a gel foam in between these two things, and the patient will be fine in the post-operative period. So I think that's all from my side. So any clarification or anything you want? So I'm ready to share with you.
So when we are asked the question, what is the differential diagnosis just after the HOPI, how do we present that answer? Like, how do we say it?
Now, in majority of the things for an undergraduate, yes, it will be a straightforward case, but they will not, as I told that in every time, because you will be presenting it as a AC polyp, somebody next to you will be presenting as an AC polyp, somebody third person will be coming and presenting as an AC polyp. So the examiner wants to just deviate from the things. Now they will be asking in between, you will be now know all the things about the AC polyp, but suddenly they will ask that if this particular patient has got a bleeding, what are the most important differential diagnoses? In this particular lady, if she has an epistaxis, then I would consider my inverted papilloma as the first diagnosis, because she is a female, more common in females. She is a middle-aged female, unilateral progressive obstruction. 5 months is pretty, I don't call it as in very gradually progressing. So there is a terms which we use has to be more careful. I call it as that it's not too rapidly also, but definitely it is not insidious and gradually progressing. If it were to be 2 years, now whatever we are seeing that they will have a 2 years, 3 years history of AC polyp. But this lady who has come with the history of 5 months with a complete obstruction is little bit has to be looked in, because there can be an underlying inverted papilloma of the maxilla which is pushing your nasal mucosa inside the nasal cavity. That are the possibilities. But for an undergraduate, yes, if you can say it is a polyp, because there are no other differential diagnosis for this. The other possibilities you can say is a meningocele, but it's too early to not in this age and all. So AC polyp is the thing for what you have told is right. But in the examination, it is not the diagnosis which is important. So how you are going to present your work and how you are going to discuss. So because invariably every one of you will be knowing your diagnosis. So there will not be a point in discussing only about the diagnosis, but the way you put your diagnosis and the way you defend yourself about your diagnosis, and when they are asked about a differential diagnosis, why you think so. So two aspects has to be very, very cleared in the examination. Okay. Hello? Hello? I think they're lost. Hello? Hello?
Hello, sir. We can hear you.
Okay.
Yeah.
So it not only for a polyp, any case now, because you people will be aggressively reading now henceforth. So now you have to get involved with you present to your own colleagues, then you can have a discussion. And as I told that, I'm not saying that it is you only one. Here also we see in all our students, you will be unnecessarily telling a lot of no's, which has to be cut down. And when you ask any particular question to the patient, you should be in a position that why you have asked that. What is the information you want to get from the patient? So that has to be very clearly understood. Okay. And now you have told that you told that the S1, S2 heard no murmurs, isn't it? I didn't object there. Hello?
Yes, sir.
And you told that normal vesicular breath sounds are heard, no added sounds. I didn't object for that also. Reason is that you have to look for that, because you are operating this patient under the general anesthesia, and there can be sometimes there may be, and without the symptoms the patient can have a murmurs.
Okay, sir.
And that is, if you don't pick up those things, then it is going to be a blunder. But here now, you don't see asymptomatic ulcers, isn't it? If the patient is having a tobacco chewer, then you have mentioned it, I would have agreed. Otherwise, how long you want to keep only no? Everything you have to say no. So there is a clear cut. I say that in medicine, if you can defend it, yes, that also. So I want to rule out the ulcers of the malignancy of the oral cavity. Then it becomes too difficult for you to defend yourself in such cases. You should have at least something. If this lady would have been either a smoker or a gutka chewer, then you would have told that, okay, no ulcers in the oral cavity. You have looked that, because you are looked in that preventive aspect. So there is no clear-cut demarcation, but if you can able to defend yourself, that's okay. And every examiner has got their own way of putting the things. It is not that, okay, I am right or somebody is right. So it's everybody has got their own ways of asking or giving a explanation. But at the end of the day, all our intention is that to make you people a good clinicians and try to impose a proper clinical methodology in you. That is our entire aim. Okay.
Thank you, sir. And we have a doubt here, sir. Like they are asking, would it be apt to mention concha bullosa among the differentials of AC polyp at the history level?
Not really, but not really. Because it is not progressive. That is what I am saying. It's not that it will not cause insidiously and so gradually progressing. In 5 months, it will cause a complete nasal obstruction.
Okay, sir.
Not in this particular patient. Unilateral concha bullosa can be a differential diagnosis for a nasal obstruction, partial nasal obstruction, not complete nasal obstruction. Okay, is it okay? Or
yeah, sir. So, do you have any ending remarks about the presentation, sir?
I didn't get you. Hello.
Do you have ending remarks about the presentation?
No, I don't know. It's a really very nice presentation. You really put everything in an order. So this is how we want every student to write it up and put the things.
Okay, sir.
But yeah, now the last slide, one slide, you would have written about the investigations also. That would be a little more complete.
Yes, sir. From the next presentation, I'll include them.
So investigations and treatment, one slide.
Yes.
Is done. And once again, I want to tell to all because now your people are very seriously reading. Lot of the observation, not only from me, majority of the teachers, that you people in the examination also will tell that give antibiotics, give analgesics. You have to be very particular about what antibiotics you want to give, how long you want to give, what is the dose which you are going to give. You have to be very careful. At least few of the antibiotics. You need not have to remember everything. So whatever the practice in our hospital, they are doing it. It varies from hospital to hospital. We do not have a universal protocol for tonsillitis. The what antibiotics they use in your hospital may be different. From GIMS it may be different. BMC it may be different. But if you can, we have got a first generation drugs, second generation drugs. So and in that way, if you can mention all those things, it will be more impressive.
Okay, sir.
Done.
So, actually, to conclude, it was indeed a very comprehensive clinical class, sir. The discussion was very useful to us. And thank you so much for teaching and guiding us, sir. We are ever grateful to you and need your blessings and support throughout, sir. And it was actually a very great effort by the presenter. We could learn a lot because of your well-prepared presentation. And thank you, Nandini. And thank you for all participants for joining us today. Thank you, Anand.
Thank you, sir.
Thank you.